So I'm a rhinologist, and every day I spend evaluating, thinking about, and working on the sinuses. So I really feel it's a privilege to be up here talking to you today about the management of acute and chronic sinusitis. So I practice in Central Phoenix with Tim, our last speaker. The objectives of my talk today are to, number one, clearly define acute and chronic sinusitis. Two, I want to outline evidence-based evaluation and treatment strategies for acute and chronic sinusitis. I hope I can promote appropriate use of imaging studies in working up sinusitis, and I also hope to promote judicious use of oral antibiotics in treatment of acute and chronic sinusitis in this day and age of antibiotic resistance. So we'll start with a case presentation. So this is patient A.E. This patient I saw in the office just 3 weeks ago. He is a 19-year-old gentleman who comes in with dad. He's complaining of 1 year of nasal congestion, thick yellow, white nasal discharge, diminished sense of smell, facial pressure, and sleep disturbance, and he's really quite miserable. His past medical history is significant for asthma and allergic rhinitis. He's been on daily fluticasone nasal spray for 6 months. So you know he's miserable if a 19-year-old is taking his spray daily for 6 months. He's not gotten any benefit with that. He's been treated with 4 rounds of oral antibiotics in the last 6 months, including 2 rounds of amoxicillin, a round of amoxiclav, and doxycycline. He's also gotten 2 rounds of oral steroids, methylprednisolone pack, and then a longer course of prednisone, and he's not gotten better. His primary care physician referred him to us for further evaluation. So when we bring patients in and evaluate them for sinonasal disorders and sinus complaints, they fill out what's called a SNOT-22 form. So SNOT-22 form, it stands for Sinonasal Outcome Test. It's a 22-item survey of nasal and sinus symptoms. They rank their scores 0 to 5 based on severity. And you can see this is his SNOT-22 form he filled out. He had a couple 5s there, nasal blockage and fatigue, and then lots of 4s. So this is a really symptomatic sinusitis patient. So when he presented, we do a full ear, nose, throat, head, and neck exam on him. And part of the evaluation is nasal endoscopy. So this is his nasal endoscopy. We're in the right side of the nose. Here, this is the right inferior turbinate. This here is the right middle turbinate. This space lateral to the middle turbinate is called the middle meatus. You can see these bubbly mucopurulent secretions in the middle meatus there. And then in the back of the nose, the choana, there's purulent secretions pooling up there as well. So that material was cultured endoscopically, and it revealed Haemophilus influenza. Because of the long duration of his symptoms, I obtained a CT scan to further characterize the sinusitis. And you can see significant sinus disease here. He's got opacification of the ethmoid and maxillary sinuses. He's got air fluid levels in bilateral frontal sinuses and the right sphenoid, and then opacification of the left sphenoid as well. So at the conclusion of this talk, you are going to be able to very rapidly diagnose this patient. You're going to be able to very rapidly counsel this patient what his treatment is going to be like, and you're going to tell him what his follow-up is going to be like. Sinusitis is a disorder that touches all of us. Everyone in this room has been touched by sinusitis. It's very common, and it affects our patients profoundly sometimes. 12% of the US population, or 1 in 8 Americans, reports having a diagnosis of sinusitis by a healthcare provider within the preceding 1 year. And chronic sinusitis patients, believe it or not, actually score lower on quality of life indices than patients with CHF, angina, and chronic low back pain. A couple of important anatomic and pathophysiologic points I want to make here. As you well know, the sinuses are hollow, air-filled cavities in our skull. They are lined with ciliated mucosa. That mucosa is constantly secreting mucus. For a sinus to stay healthy, that mucus needs to get out of the sinus. And that is something that's happening 24/7, running in the background all the time. The cilia, which this is what cilia look like under a scanning electron microscope. They look like a shag carpet or a field of long grass. They are constantly sweeping and beating the beating in a coordinated fashion, pushing the mucus towards the ostium. And that ostium drains to an area in the nose called the middle meatus. The middle meatus is an important anatomic component to look at when you're trying to evaluate for sinus disease. Left nasal cavity, left inferior turbinate, left middle turbinate, and this is the middle meatus. The frontal, anterior ethmoid, and maxillary sinuses all drain to that bottleneck area. So that's an important area to look for pathology. We all know what sinusitis symptoms are. I've listed them here. These patients can experience purulent nasal discharge. Now that can either be anterior, where it drips or runs out of the nose, or they blow it out of their nose, or it can be posterior, where it drains down into the nasopharynx and down into the throat. They experience significant facial symptoms, pain, pressure, fullness, nasal congestion, nasal obstruction, and then you see the litany of other complaints they can have. But I wanted to highlight these top symptoms here, because not all sinusitis symptoms are weighted equally when you're trying to make a diagnosis. And we have specific diagnostic criteria for sinusitis that you will learn in the next few slides. And these symptoms here are much more important than all these others. I like to group those symptoms into the 3 Ps. The 3 Ps are pus, pressure, and plugged. Pus refers to the purulent nasal discharge, or what we call in the rhinology world mucopus. The pressure are these facial symptoms, pain, pressure, fullness, and plugged refers to the nasal congestion and nasal obstruction. How about definitions for acute and chronic sinusitis? Well, it's actually very, very simple, very straightforward. Acute rhinosinusitis is sinusitis present for less than 4 weeks, and chronic sinusitis is present for greater than 12 weeks. There are 2 types of acute rhinosinusitis, viral and acute bacterial. So acute rhinosinusitis, diagnostic criteria, whether you're talking about viral or bacterial, the acute rhinosinusitis diagnostic criteria are up to 4 weeks of purulent nasal discharge, so that's the mucopus, and they have to have one of these 2 to get diagnosed with acute sinusitis. So they either have to have facial pain, pressure, fullness, or nasal congestion. So again, that's back to our 3P criteria. I want you to keep that in mind. They have to have pus, and then one of these 2, pressure or plugged. I want to highlight the fact that if they don't have mucopus, they don't have sinusitis. You can't diagnose sinusitis unless they have mucopurulent nasal discharge. And the reason to stay very disciplined about that is because there are lots of diagnoses that can be mistaken for acute sinusitis, such as migraine, tension headache, cluster headache, and temporomandibular joint disorder, because those diagnoses share similar sensory experiences in the first and second branch of the trigeminal nerve as acute sinusitis. And Dr. Hurley is going to talk to us at length about other sources of sinus headache. Viral rhinosinusitis. So viral rhinosinusitis is one of the 2 types of acute sinusitis. So these patients have met the 3P criteria, so they have mucopurulent drainage, and then they either have facial pain, pressure, fullness, or nasal congestion, and their symptoms are less than 10 days. So all you need to remember for acute viral rhinosinusitis is the 3 Ps and less than 10 days. 3 Ps, less than 10 days. Acute bacterial rhinosinusitis, on the other hand, these are patients who've met the 3P criteria, and they have symptoms for greater than 10 days. So it's a pretty clear delineation at 10 days. The other way you can kind of get to get a backdoor diagnosis of acute bacterial sinusitis is if symptoms are worsening within 10 days after an initial improvement. So you could get diagnosed with bacterial sinusitis in less than 10 days if you have sinusitis symptoms, and at day 4 you start getting better, and then at day 7 you get acutely worse. That is acute bacterial rhinosinusitis, even though it hasn't gone 10 days. So how do we get from viral rhinosinusitis to acute bacterial rhinosinusitis in 10 days? Well, what happens in this sinus cycle is you get exposed to a virus. It can also happen with some allergic or environmental sensitivity, but the viral model we'll talk about. So a virus enters the nose. It causes mucosal edema in the middle meatus. Your ostia of your sinuses become obstructed. This guy moves in. You get mucostasis. When mucus sits around in a body cavity, it's going to grow bacteria. You get acute bacterial rhinosinusitis. You get more mucosal edema. The ostium remains closed, and you're in this vicious sinusitis cycle. Let's highlight the difference between viral and bacterial sinusitis further with some pearls and Stats. So viral rhinosinusitis occurs 2 to 5 times per year in the average adult. However, only 1% of viral rhinosinusitis episodes will eventually become a diagnosis of acute bacterial rhinosinusitis. Also, it's important to note that viral illness symptoms are usually improving by day 5. And interestingly, fever and facial dental pain do not predict bacterial infection. So you can get that with the viral rhinosinusitis. And also interestingly, which when I graduated from medical school, I would not have thought this, but purulent nasal discharge does not predict bacterial infection. It only indicates that neutrophils are present. So studies have been done, and you can get purulent nasal discharge, no bacteria. It's just neutrophils there. Chronic sinusitis, greater than 12 weeks of sinusitis symptoms. You have to have 2 or more of the following symptoms: mucopus, nasal obstruction, congestion, facial pain, pressure, fullness. So these top 3 we're used to already talking about. Those are our 3P criteria. But here's this new one that's introduced for chronic sinusitis: diminished sense of smell. So in those patients complaining of diminished sense of smell for 3 months, think about chronic sinusitis as a diagnosis. The other thing that's different about chronic sinusitis, other than time course, from acute sinusitis, is that you have to have one of these objective findings to make the diagnosis. So you cannot diagnose chronic rhinosinusitis without documenting in the chart one of these objective findings. And these are purulent mucus in the middle meatus, edema in the middle meatus, polyps in the middle meatus or somewhere in the nasal cavity, or radiographic evidence of sinus inflammation. So we're going to jump in and now start talking about evaluation and treatment once we've got it defined now. In 2015, the American Academy of Otolaryngology Head and Neck Surgery actually came out with clinical practice guidelines for adult sinusitis based on current evidence. So I'll be highlighting the clinical practice guidelines, and then I'll be sprinkling in some other review articles and some of the other data to help us treat these patients. What about imaging in acute sinusitis? Something we often wonder about. Well, imaging is not recommended at all when you already have the diagnostic criteria met for acute rhinosinusitis. And the reason for that is because CT scan cannot distinguish between a viral URI, viral rhinosinusitis, or acute bacterial rhinosinusitis. If you do a CT scan on a patient with just a cold, you're going to see air fluid levels, you may see mucosal thickening, so the CT scan doesn't help you. A person with a cold can have an abnormal CT. Also, imaging is appropriate, however, when you suspect there's a complication of the sinusitis. So in patients who present with sinusitis symptoms plus severe headache, facial swelling, cranial nerve palsies, proptosis, significant epistaxis, those are patients there might be a complication going on, or in the case of epistaxis, maybe some malignancy growing in there. And so you'll want to get a CT on those patients. I also want to highlight, and this comes from the American College of Radiology, that plain x-rays are not indicated at all for working up sinus disease. And the reason for that is that they are inaccurate and they just don't help. So the American College of Radiology actually recommends you do not get plain x-rays when you're talking about sinus disease. The appropriate studies for paranasal sinuses are, however, CT scan and MRI. If you suspect extra sinus complications, so if you suspect the patient has an orbital cellulitis or an orbital abscess or some type of intracranial pathology going on, secondary to their acute sinus infection, you want to get imaging with contrast because we're looking for things like abscess pockets that will have rim enhancement. Okay, treatment. So viral rhinosinusitis treatment. Once you make the diagnosis, you know you're not dealing with bacteria, so you're not going to be writing an antibiotic script, but you want to offer these patients symptomatic relief because they can be quite miserable. It is recommended based on the current medical evidence that you offer these patients or recommend analgesics and antipyretics over the counter, such as acetaminophen and ibuprofen. Nasal saline irrigation has been proven to reduce symptoms in viral rhinosinusitis, and topical nasal steroids have been proven in the literature to reduce symptoms in viral rhinosinusitis. So you can recommend these patients go over the counter, pick up some fluticasone or Flonase nasal spray, and use it daily for 2 weeks. There is not much supporting evidence with respect to randomized controlled trials for these things, but the clinical practice guidelines say you know what, it's probably reasonable and you can make the recommendation for oral decongestants. Topical decongestants are generally helpful as long as they stay less than 3 days of use, otherwise they'll get rebound. Oral antihistamines for viral rhinosinusitis, and mucolytics, expectorants, and cough suppressants. Okay, what about acute bacterial rhinosinusitis? So this is what everyone's been waiting for. Clinical practice got exciting, right? The clinical practice guidelines recommend that once you make that diagnosis of acute bacterial rhinosinusitis, it's clinician's choice. You can offer the patient observation, or you can offer them an antibiotic prescription. And so specifically, you offer watchful waiting without antibiotics, or you can prescribe the antibiotic therapy. Well, what does watchful waiting look like? Well, this means observing the patient for up to 7 days after the diagnosis of the bacterial sinusitis. And this is for patients with uncomplicated sinusitis. This is for patients that you trust will come back if they're not getting better, and they're not going to end up in an ER with a complication. Okay? There are evidence-based options during watchful waiting. This is basically the same thing you would do for viral rhinosinusitis. So if you're not going to give the bacterial sinusitis patient a script for antibiotics, you're going to recommend analgesics and antipyretics. You're going to recommend topical nasal steroids, which have been proven to help in acute bacterial rhinosinusitis, and nasal saline irrigation as well. The one caveat with nasal saline irrigation, different than viral, is that the hypertonic saline was found to be more beneficial than isotonic saline in the bacterial sinusitis. And what that practically means for you is 2 packets of Neomed in 1 bottle instead of 1. These other things here, other options, not strong evidence in the literature, but there is some evidence. Topical decongestants are helpful in acute bacterial sinusitis when limited to 3 days. What about antihistamines? Clear benefit in allergic patients in some studies, no benefit in non-allergic patients. What about oral steroids? So you have this patient in front of you, they have acute bacterial sinusitis, they're edematous, they're plugged, they're miserable. You want to give them some relief. You know the steroids are going to bring the edema down. Well, it's been looked at in the literature, no benefit. One cool thing you can do for your acute bacterial rhinosinusitis patients when you're doing observation is a SNAP. So a SNAP is a safety net antibiotic prescription. And the way you do a SNAP is you tell the patient, look, you have acute bacterial rhinosinusitis. The literature says that we may not need to treat you with antibiotics and you might get over it on your own. But what I'm going to do is I'm going to give you a prescription for antibiotics, and I only want you to take it if your symptoms don't resolve in 7 days, or if you get acutely worse during that 7-day observation period. And you just ask them, hey, please call the office so we can document in your chart that you took the antibiotic. And patients appreciate this because it avoids an expense and inconvenience of another appointment. All right, so what if you make that decision to go ahead and give them an antibiotic? The current medical evidence says it's clinician's choice. You can give them amoxicillin or amoxiclav for 5 to 10 days for acute bacterial rhinosinusitis. Those are the clinical practice guidelines. For penicillin allergic patients, you can give them doxycycline for 5 to 10 days, or respiratory quinolone, levofloxacin or moxifloxacin for 5 to 10 days. For patients who can't take penicillin, but they did not have a type 1 hypersensitivity, meaning they don't have anaphylaxis to penicillin, you can give them a cephalosporin 3rd generation combined with clindamycin to get the same coverage as amoxiclav. The bacteriology of acute bacterial rhinosinusitis, I'm very happy to report. This is the same thing I learned in medical school. So most infections are going to be due to strep pneumo, H flu, 22 to 35%, Moraxella catarrhalis coming in 3rd here, 2 to 10%, and Staph aureus is going to be causing about 10% of acute infections. Beta-lactamase production is significant in these infections. Strep pneumo is going to have anywhere up to 25% beta-lactamase production. H flu strains are going to be producing beta-lactamase in up to 43%. And Staph aureus, nearly 100% of Staph aureus strains produce beta-lactamase. And that's kind of why in my armamentarium, I go with amoxiclav. How do we get to 5 to 10 days for duration of therapy? Well, this has been looked at extensively in the literature. There was a systematic review of 12 randomized controlled trials. And what they found is there's no difference in symptom control between short, i.e. 3 to 7 days, and intermediate, 6 to 10 days of therapy. As you can imagine, the adverse events from the antibiotics were greater in the 10-day group. What about oral steroids with oral antibiotics? This has been looked at in the literature, and there is indeed a modest improvement in acute bacterial rhinosinusitis symptoms when you combine an oral steroid with an oral antibiotic. In the literature, these were short courses of oral steroids, so 1 to 2 weeks. And just remember, it's important to discuss the side effects with the patients. What about the patient who fails initial antibiotic therapy? Well, what you want to do with that patient, since they've been on antibiotics and they didn't get better, you're going to bring them back into the clinic. You're going to reevaluate them and confirm that you're actually dealing with acute bacterial rhinosinusitis. You want to evaluate for complications, look for periorbital edema or erythema, proptosis, see if they have vision changes or severe headache. If they have any of these, that means a stat ENT consult from your favorite ENT buddy, or you want to get a CT scan with IV contrast, or both. If the diagnosis is still uncomplicated acute bacterial rhinosinusitis when you see them back, you're going to change the antibiotic. The recommendations for changing the antibiotic from the literature are if they failed amox or amoxiclav, you change to high-dose amoxiclav. So 2 grams BID, or the smaller patient, 90 mg per kg per day divided BID. Or this is a chance to jump and go ahead and switch to a tetracycline, so switch to doxycycline, or your respiratory fluoroquinolone, or again, you have that option in patients who don't have anaphylaxis to penicillin. You can go with a 3rd generation cephalosporin and then clindamycin. Okay, treatment of chronic sinusitis. So this is a very broad topic, so I'll just be giving you some of the highlights. But again, chronic sinusitis is greater than 12 weeks of symptoms, and remember, you have to find that one objective finding. So this is, you can't just get from talking to the patient, you actually have to find one of these things here: mucopus, edema in the middle meatus, polyps, or some radiographic evidence. Well, how are you going to make a CRS diagnosis in the primary care setting, okay? Because you've got to look in the area of the middle meatus. Well, you can do that on your exam, on your primary care exam. You're again going to be looking for polyps, edema, or mucopus. So you can do that with a good otoscope exam with the plastic speculum. You just have to really get way up in there and look and take your time. This is a nasal speculum that can assist in your anterior rhinoscopy, the anterior visualization of the nasal cavity. You can get these for like $10 on Amazon. This is a very inexpensive headlight that people use, that I use for hiking and running at night and stuff, or early in the morning. You can get these sporting goods stores. Very inexpensive stuff that can help you with these sinus patients and looking up in the nose. Also, you have radiography at your disposal. So you could order a limited sinus CT scan, or you might be able to get to the diagnosis with objective findings through the back door here. Check and see if the patient had an MRI of their head in the last year or 6 months. You may find that the radiologist read that there was mucosal thickening incidentally, assuming incidentally on the MRI, or you can pull the images yourself and look for mucosal thickening. So you can sometimes get to the diagnosis that way without ordering a new study. So this is, if you really get up in the nose with your nasal speculum and headlight or otoscope, you can get this kind of view here. This is the nasal septum. This is the nasal sidewall. This here is the middle turbinate, and this is a polyp up in the nose. They're a little more shiny and translucent. So it's important when you make the diagnosis of chronic sinusitis, you want to know if the patient has polyps, because it can open up the door to additional therapies for the patient. There are many different things that can cause polyps that are beyond the scope of this talk. I just want to highlight that unilateral polyposis raises the suspicion for neoplasm. So you want to get an ENT consult or imaging on this patient that has unilateral polyps. Make sure they don't have a tumor growing in there. You also want to evaluate for modifying factors. So you want to ask these patients about their allergic rhinitis history, or get them sent off to the allergist for allergy testing, or do it if you do it in your own practice. Asthma, you want to ask about asthma. The reason is medical and surgical treatment of chronic sinusitis has undeniably in the literature shown benefit in asthma symptoms. Also keep in mind cystic fibrosis patients, especially the heterozygous patients, so if they don't have double alleles of CF gene, but they just have one copy. These patients have a mild form of CF, and they are going into and out of all of our offices with chronic sinusitis symptoms. So sometimes you need to send them off to the immunologist for testing. Also keep in mind immunodeficiency, especially if the patient complains of recurrent otitis and bronchitis. Think immunodeficiency. I screen all my sinusitis patients for vitamin D deficiency. That is a risk factor for recurrent acute and chronic sinusitis. So always check vitamin D. And then here are some of these other things that you'll want to get sent off to the allergist immunologist so they can screen for that. Treatment of chronic sinusitis is diverse. Most of the treatments are medical. We're going to try to reduce this chronic inflammatory disorder with medicines first and reserve surgical intervention for the patients who don't respond. There are only two things that have been rigorously studied in the literature with multiple randomized controlled trials that show benefit and safety, and that is nasal saline irrigation and topical intranasal steroids. So every patient you diagnose with chronic sinusitis, you can confidently tell them, you should be on this. It will help you if you do it every single day. A brief note about xylitol. This is something that I found interesting and anecdotally helpful in patients. The addition of xylitol to saline in a rinse form has been found to be superior to saline alone for symptom control in CRS patients. And xylitol is interesting in that it's antimicrobial and it inhibits bacterial adhesion to sinonasal mucosa. Antibiotics in chronic sinusitis. So ironically, antibiotics are the most common prescription given for chronic sinusitis patients, but there's a huge gap in our evidence. We do know that culture-directed therapy for acute exacerbations of chronic sinusitis are best. There's also some anti-inflammatory effect of some antibiotics that we use to help these patients. The anti-inflammatory effect of macrolide antibiotics is very similar to what happens in the asthma literature, where you put these patients on long, 6 weeks of therapy and they get mucosal inflammation reduction in both their sinuses and their lungs. And doxycycline was actually found to have benefit. It can shrink polyps as much as prednisone can shrink polyps in one study. So in addition to the antimicrobial effect, there's some type of anti-inflammatory process going on. What about short-term therapy versus long-term therapy in chronic sinusitis? You may be thinking, well, these patients have chronic disease. Let's put them on antibiotics for a long time, see if they get better. Well, that's been looked at, and there's clear evidence supporting short-term treatment of acute exacerbations. What we don't have good evidence on is long-term antibiotic therapy for patients. The Cochrane database of systematic reviews looked at this, and they looked at 12 weeks of macrolide therapy for chronic sinusitis patients. They did find that these patients were better when they were on 12 weeks of daily macrolide therapy, like clarithromycin, but that when they measured their symptoms 3 months later, all the benefit was lost. Oral steroids are a common prescription for patients with chronic rhinosinusitis. Side effects are very significant, as you can see there. This was looked at in a systematic fashion. Cochrane Reviews 2016 looked at multiple randomized controlled trials, and they found that short courses of oral steroids for 2 to 3 weeks at a time were beneficial for chronic sinusitis sufferers. But if you measured their symptoms 3 to 6 months down the road, they were kind of back to their baseline. So it does help patients get through tough times, but they're going to kind of fall back to their baseline and rely on those saline irrigations and topicals and nasal steroids to keep them well. Patients with nasal polyps generally get more of a response from steroids. So if you're thinking about risk-benefit ratio, that patient with polyps, it's probably a good reason to do oral steroids. And what patients with polyps will tell you, and they love it when they go on steroids, is that they get their sense of smell and taste back. So they'll really thank you for that. So you get a lot of requests right before Thanksgiving for steroids. This is the side effect sheet we give all of our patients. If they walk out of our prescription, if they walk out of our office having been sent a prescription for oral steroids, I do a verbal conversation about the steroid risks, and they also get this sheet. Other therapies, very diverse. Most of these other therapies listed here, I wanted to include them because you're going to see them on the med list of your patients coming in to see you. Oftentimes they're prescribed by the allergist, or in the case of montelukast, for example, you may be prescribing it. But leukotriene antagonists are helpful in allergic rhinitis and asthma and have some benefit in chronic rhinosinusitis with nasal polyp sufferers. Anti-IgE therapy is something that's very exciting, and I'm personally kind of excited about this because anecdotally I'm seeing patients get put on Xolair, which is a monoclonal antibody for IgE, for their asthma, and I'm watching their polyps melt away, which is really cool. And anti-IL-5 therapy, again, monoclonal antibody for IL-5, which reduces eosinophil activity. These patients, again, some anecdotal benefit, no good studies in chronic sinusitis with nasal polyps yet. Aspirin desensitization, on the other hand, these patients, AERD or Sampras triad, they have the triad of aspirin sensitivity, nasal polyps, and asthma. This is one of the most difficult forms of nasal polyposis to treat because their polyps are highly recurrent. Patients who get on aspirin desensitization, which is essentially an immunotherapy of aspirin, they take aspirin every day to decrease their environmental sensitivity to salicylates and other irritants. They do better in the literature, improve nasal and asthma symptoms. But this is a big deal, and for patients to get aspirin desensitization, it has to be done under the care of an allergist immunologist. And the thing about it is when you start them on aspirin and immunotherapy, they anaphylax. So basically it's controlled anaphylaxis by the allergist immunologist to get them up to speed. Endoscopic sinus surgery is a treatment option for CRS patients who don't have sustained benefit from maximal medical therapy. So maximal medical therapy, in my mind, is a patient who's on saline irrigations daily. They're on topical nasal steroids daily. They've been treated a few times throughout the year with oral steroids and oral antibiotics. That's a patient who needs something else. They need some help. We can also shortcut to endoscopic sinus surgery for patients with complications of sinusitis. We're going to operate on those folks right away to drain the inciting infection. But the goal of endoscopic sinus surgery in patients with chronic sinusitis is we want to open up, we want to restore ventilation, restore drainage of the sinuses so that mucocillary clearance can happen. But really what we're doing is we are opening up the sinuses to get more topical therapy in there. So that's the benefit in the chronic sinusitis patient, so that after surgery they have a new, better baseline and their topical therapy can keep them there. Functional endoscopic sinus surgery is what we refer to nowadays. So we're not going in and scraping out the lining of the sinuses anymore. We're just opening up the bottleneck area that's obstructed. Technology has allowed surgery to move forward without packing and decrease pain. So most of the patients, when I counsel them about surgery in my office, I say you're not going to get black and blue, you're not going to get swollen on the outside. When you wake up in recovery room, I expect you to be breathing through your nose. There are numerous large, well-organized studies to show benefit for chronic sinusitis with and without polyps. These patients have improved symptoms in the literature, decreased antibiotic and steroid use. Revision surgery is an issue. Patients do ask about this. You may wonder about it. 15 to 20% of patients across the board may need another sinus operation. And there's an increased risk of revision surgery in certain populations, like the aspirin-sensitive patients, cystic fibrosis, and somebody who has extensive polyps. So, to summarize, acute bacterial rhinosinusitis. It's acute rhinosinusitis that's been present for 10 days, and they meet the 3P criteria. So remember, 3 Ps in 10 days. You're going to treat acute bacterial rhinosinusitis with 7 days of observation and a SNAP, or you're going to prescribe a MOX versus a MOX-CLAV for 5 to 10 days. CT scan is only indicated in a chronic sinusitis workup or when you suspect complications. It's not indicated in acute rhinosinusitis if you have the diagnostic criteria already met. CRS or chronic sinusitis, that's 12 weeks of symptoms confirmed by one objective finding. When you diagnose chronic sinusitis, evaluate for polyps, asthma, immunodeficiency, CF allergy, and aspirin sensitivity. And then the basics of chronic sinusitis therapy. All patients should have tried saline irrigations. They should be on a daily nasal steroid. It's proven to be effective to treat patients with PRN, oral steroids, and oral antibiotics for 2 to 3 weeks at a time. And surgery is reserved for patients with recalcitrant symptoms. All right, thanks.
If you diagnose a patient with acute bacterial rhinosinusitis and you decide to do a 7-day observation instead of antibiotics, is there any data on what percentage of patients get better after just a 7-day observation?
That is a good question. I don't know the answer to that. My guess is, from anecdotal experience, is that most of them are going to. I'm not seeing a lot of those patients You guys are experts more on the person who is, it's debatable whether they're viral or acute bacterial, and whether or not they'll get better with a 7-day observation period. What I think is that most of them do, but I don't know the data on that.
Any benefit in nasopharyngeal cultures? I haven't heard anything about that.
Any benefit in nasopharyngeal culture?
That has been looked at in the literature, and there is no benefit. So the flora are different. If you swab the nasopharynx, you're going to get different organisms grow than if you were to directly puncture and aspirate the maxillary sinus. So that's been looked at in controlled studies. So you're getting organisms from the nasopharynx that are not responsible for their infection. So what we do in our office, and this has been validated, is you do an endoscopy, and you have to collect the mucopus from the middle meatus. And when we found that when you collect the mucopus from the middle meatus, it's the same organisms that they're aspirating direct puncture from the antrum of the sinus. So we feel confident in that, but once you swab the nasopharynx, you're getting all kinds of, just normal microbiome stuff.
I have heard that some physicians have advocated for getting a pneumococcal vaccine to minimize the occurrence of some of the organisms seen in the sinuses. Is that in any literature?
I don't know, is the short answer. I am seeing my allergy immunology colleagues doing that on folks who have recurrent acute sinusitis. My gut tells me it's appropriate for, select populations. I think the patients, my gut also tells me it's probably not just advisable to do that on your average healthy patient. And they probably should have some screen as to seeing whether or not they have an inadequate response to that pneumococcal vaccine. One more question. Yeah. Oh, yes.
Going back to your case study on the 19-year-old male, he had H. flu. He was treated with maybe appropriate antibiotics. What do you think was going on with him?
So he was in that vicious sinusitis cycle where he had obstructed ostia. And so what was happening is you're giving him antimicrobial therapy. You're reducing the bacterial load in the mucus, but that mucus remains. So presumably we were sterilizing his mucus with antibiotics, but the mucus remained in the cavity. And it was just a matter of time before that mucus repopulated with new bacteria. So that's a patient who can benefit from functional endoscopic sinus surgery to improve the mucocillary clearance so that the sinus remains empty. It's not, I tell these patients, look, it's not really the bacteria that are the problem, it's the mucus stasis. So if we make it inhospitable for bacteria to live, i.e. we prevent a pool of stagnant mucus, then there's no place for the bacteria to thrive. So bacteria are just opportunists here.